Introduction to fixed prosthodontics. A fixed prosthodontics is that branch of prosthodontics concerned with the replacement or restoration of the teeth by artificial substitutes that are not readily removed by the mouth. The scope of fixed prosthodontics, where all we can use fixed prosthodontics: rehabilitation of single tooth, like we can see here, to the entire occlusion, rehabilitation of the entire denture fixed with the implants. Now the terminologies that we will come across is extracoronal restoration and intracoronal restorations. Extracoronal, coronal means the crown part. So anything outside the crown restorations will be called extracoronal restoration, like crown, like bridges. Intracoronal restoration, anything that comes inside the crown, like precision attachments, those will be called as intracoronal restorations. Now the crowns, what are the different types of crown that extracoronal restoration can be? It can be full veneer. Veneer means covering. Basically veneer means covering. So full veneer, full covering. For example, we have metal, we have ceramic fused to metal, that is also called porcelain fused to metal. All ceramic restoration, we have resin and metal, we have resin crowns. And partial veneers, we have 3/4, we have half quarters crown, we have 7/8 crowns, those are called partial veneer crowns. Intracoronal restorations like inlays, onlays, inlays where we have metal inlays and ceramic inlays. The same is with onlays, we have metal onlays, we have ceramic onlay. Where do we use inlay and where do we use onlay? If the cusp is intact and anything is destroyed inside the carious part is inside the crown, then we will use inlay. If the cusp is not intact anymore, in those cases we will use onlay. You can see very well, so when the restoration of the cusp tip, then that is called onlay. When there is restoration only inside the crown, that is called inlay. All ceramic laminate veneers, these are the new coming up technology where everybody is desired of aesthetics. All ceramic gives an excellent aesthetical properties, translucent properties and color properties. So these are all ceramic restorations, fixed partial dentures. We can see, when do we call it fixed partial denture and when do we call it crown? So crown is for the single tooth. Fixed partial denture is when we have to replace one missing area. So you have to have a bridge between two different natural teeth. That time it will be called as fixed partial denture. Treatment planning for a single tooth restorations. Let us see your single tooth restoration. It can be intracoronal restoration, like you can have a feeling of GIC, composite amalgam, we have complex amalgams, we have metal inlays, we have MOD onlay or ceramic inlays. For extracoronal restoration, we have full veneer crown, we have partial veneers, we have porcelain laminate veneer crowns. Treatment planning for multiple missing teeth, then you have to fit many factors into consideration, that is the space present, the opposing occlusion which is present, where we are supposed to end the occlusion of the maxillary arch, how much it has supra erupted. All those factors has to be taken under consideration. Planning for a missing teeth in a longer duration. Now, why do we replace a missing teeth? Is it important to replace a missing teeth? The first basic question a patient asks you. So, replacement of missing teeth is important. Say for example, in a bookshelf, when you have all the books lined up one by one, you remove one book, the other books will fall in that particular place. This is what happens when this particular teeth is missing. All the teeth tends to come in this particular space. So this is supra eruption, this is mesial drift, this is distal drift of the mid, and this space is lost. So this is why replacement is important, whether of anterior segment or a posterior segment. Why? Because it is important, because all of us do have a dynamic equilibrium and motion. So all the teeth is in moving position. When it has something in nearby in the neighbor, it will not move. Space is plot is empty, it will move into that particular place. See, we can see supra eruption of these teeth in the missing area. We can see supra eruption. So this is all dynamic equation. So it will ought to happen. So you need to replace with a bridge. We can see the green one, there is a bridge. Up you can see a green one, there is a crown. So because tooth is present, we have given a crown. If there is no tooth present, we will take support of the adjacent teeth and give a bridge to that particular section. Now what are the ways to replace a missing teeth? It can be either fixed or it can be either removable. Now we need to see What are the aims of restoration? Basic aims of restoration is aesthetic, function, of course, comfort, stability and maintainability. A restoration which is coming into a particular missing area should be able to maintain its own hygiene by itself. It should be cleansable. It should not cause any odor to the oral cavity. It should be functioning properly for the mastication and it should look good. Coming to the definition of fixed prosthodontics, the branch of prosthodontic concerned with the replacement or restoration of the teeth by artificial substitute that are not readily removed by the mouth. Now, what are the parts of that? Now, a teeth on which the bridge is going to come, the support from where we are going to get, the teeth is called abutment. The part on which that is going to come is different. Now, we are talking about the teeth. So, the abutment is a tooth or a portion of tooth or that portion of dental implant that serves to support or retain a prosthesis. Now, retainer is that part of fixed prosthodontic. Retainer is that part which will go on to the abutment. So, the parts of fixed prosthodontic is not abutment. It is the retainer. Abutment to the remainder of the restoration. Connector which connects the pontic. What is pontic? Pontic is the one which is replacing the missing tooth and restore its function. Usually fills the space which is previously with the help of the clinical crowns. And pontic we told, and connector is which is joining the pontic and the retainer. This section will be called as the connector. Connectors can be of two types, rigid connector and non-rigid connector. Non-rigid connectors like tenon mortise connectors, those are non-rigid type of connectors. Indications for removable denture are many missing teeth, no distal abutments present, you have to go for removal partial dentures. Bilaterally dentulous space, you have to go for that. Tip teeth as an abutment, gross alveolar restoration, young patient, still growing, large pulp, parodontally weak patients, weakened teeth. But when will you say that no, we are not going to go for removal partial denture is when the patient's mental status is not great. When unfavorable oral hygiene is present, xerostomia, loss of saliva and muscular discoordination. So what are the reasons for fixed partial dentures? Are these that more acceptable to the patient, it is not supposed to be removed, not supposed to be placed back, abutment teeth are parodontally sound, short edentulous span, no gross soft tissue defect is present. Different kinds of restoration of fixed partial dentures are present. One of them is called resin bonded. Resin bonded, what does that mean? Something which is bonded with resin, composite. So something if it is bonded with composite, that means we are not preparing the full teeth. We are giving some grooves in the teeth and fixing it with the help of composite, like in case of deep bite or abutment mobility when the abutment already is mobile. So in those cases, you will put some small pits and fix the FPD with the help of composite. An implant supported FPD where implant is placed and on that fixed partial denture will arrive, that is called implant supported FPD. Now two of fixed partial dentures can be a conventional fixed type of denture. In conventional fixed type of denture, you have two teeth on which there will be a bridge and the supporting pontic will take over the place which is missing. Fixed type, all the joints are soldered or cast in one piece. Rigidly it is connected all the abutment teeth and it requires good retention at either end of the span. That means presence of sound tooth structure is important. Cantilever is what? When something is not there on the other side. One tooth is replaced with the help of one abutment. See for this green color which is replaced with only this teeth. It is not connected to this natural teeth. But this kind of case is only indicated in cases of maxillary lateral incisors or mandibular lateral incisors and centrals. It is not indicated for any other long span cases, especially not indicated for posterior region, which is most into practice and very unethical. Spring cantilever is when we are taking the connection of the abutment of the retainer from a different zone. See, the retainer is over here and with the help of a bar, we are giving this pontic. So this kind of restoration is called spring cantilever. Fixed movable how will the thing be movable? Then it has to be a non-rigid connector, like tenon mortise connector. In that, what happens? You have a male component and you have a female component. So this male component goes and fits into the female component, and this is how it becomes non-rigid connector. And so when there is a movement, so what will happen? There is a flexibility allowed with the help of restoration. So all the pressure of the force of the mastication will not be transferred to this particular tooth as well. The force will be broken over here. So it is also called as stress breakers. Now coming to, is that any teeth can be used as an abutment? No. For an abutment to be chosen, there are different criteria which has to be followed. So the abutment selection is based on the occlusion forces. It is based on the number of abutment teeth. It is based on the pontic, that is number of missing places which is there. So we need to decide on these factors of the occlusal forces, abutment teeth, which is present, number of missing teeth that we have to replace. Based on that, we have to start selecting the abutment. Coming on the requirements of an abutment, the vitality of the teeth is important. If endodontically it is treated, it has to be sound and asymptomatic. Supporting tissue should be healthy. The periodontium should be healthy. There should not be no mobility, should not be there. And most important, the bones should be very much supporting. Roots and supporting tissues should be sound enough and no caries. Caries and restorations, if present, should be completed. Endodontic status of the particular tooth is to be selected, is to be checked whether the root canal which is done is sound, it is no symptom is present. Size of the pulp chamber we need to assess and analyze if we are doing a vital tooth preparation. Post and course if required. If the clinical crown that is present to us is not adequate, then we need to know about the post and course. That is an option. Now factors affecting the selection of abutment teeth. Looking after the periodontal status of the particular tooth, we need to see about the mobility of the teeth. We have to see if there is any pocket depth present, if there is any plaque, if there is any mobility or bleeding on probing present. All these say that your teeth is unhealthy. And when our teeth is unhealthy, we cannot proceed for it to be abutment for a fixed partial denture. Coming to roots and supporting tissues like the crown root ratio, root configurations, periodontal ligament area, will come one by one to all of these. The first one is the crown root ratio. Now what should be an ideal crown root ratio? It should be around 2:3. But if not present, at least it should be 1:1. Because more than that, if crown is bigger and root is smaller, then again it will cause cantilever. There will be an offset load on this particular section of the crown and it will tip the crown which is we are giving. What are the force that is coming, the occlusal force that is coming on to each tooth? For anteriors it goes up to 26 lb. For around a denture teeth it goes up to 54 lbs. Whereas for the posterior it goes up to 150 lbs, the masticatory force of a human being. So as the bone level decreases, the lever arm also increases in these cases. Coming to root configuration, which kind of configuration of root is good? So tapering is good or ovoid is good? No, ovoid root configuration is good. Longer roots are better. So canine is a good abutment. Whereas also centrals are good abutments. We need to also see for the root configuration that 1 mm of root is left all over after the pulp chamber. In case we are going for a post and core, we need to see the adequate width that is present around the particular pulp chamber is minimum of 1 mm or 1/3 of the total width. And also like here this, you can see this root, how it is, it has two different root, whereas this is converging root. So converging root is again bad for us because surface area is decreasing. Here the surface area is more. More the surface area, less will be the force acting on that. Now periodontal ligament area. Here Sir Anti gave a law which supports and says that the pericemental, the sum of the pericemental area of the total root surface should be equal or surpass that of which is to be replaced. That means, what does that mean? 1 is to be replaced with the help of 1. This is fine. 2 is to be replaced with the help of 1 root and this molar, so it has 2 root. So this is also okay. But if 3 has to be replaced with two roots, that is violating Ante's law. So that means that the pericemmental area of what is to be replaced should be equal or more than that of to be replaced. The abutment should have more roots, more surface area than the pontic area. So coming to now the biomechanical considerations for abutment selection. So deflection of flexure, double abutments, grooves and arch curvature. So we will come to one by one. Coming to the first one, there is length of the span. Now if the length of the span will increase, the stress on the abutments will also increase. Now length of the span will increase, it will also lead to flexional forces. Now this flexional forces will be almost 3 times that of the force normally coming. So if in anteriors we have 20 lbs of force, the abutment, if it is long, the flexional force will be thrice. So that will be 20 ka cube, that is 80 lbs. So similarly, look into this characteristic. If this is x, so the flexional force here will be 2 times that of the x. The deflection which will be formed will be more in the between. So the force on the abutment teeth will be thrice. So more detrimental forces are falling on the abutment and we are losing to the healthiness of the abutment. So abutment selection cannot be in a long span FPD. So long span FPDs are contraindicated. Short span FPDs are fine. So what will we do if it is a long span case? Either you go for an implant or else you go for a removable partial denture but not a fixed partial denture. Alloy with high yield strength, that is nickel chromium, all FPDs flex. Any FPD will flex if you have a long span. Single crown, buccolingually, and we have FPDs mesiodistal direction, it will start flexing. If it is a single crown, it will flex in buccolingual direction. If it is a fixed partial denture, it will start flexing in the mesiodistal direction. What is double abutments? We have secondary abutments. If our primary abutment is not enough to support the fixed partial denture and the pontic that we are planning, use the side neighboring tooth as well, and they will be called as a secondary abutment, so that the stress will be distributed between two abutments. For example, here this force is distributed between this and this teeth, here this teeth and this teeth. So the crown root ratio or the tensile forces are retentively more. So it will retain more, the prosthesis will retain more because the root surface area is distributed and also it is following the Ante's law. Now coming to the arch curvature, or it is also known as AP span, antero-posterior span. What curvature of arch is favorable for us? A tapered one, or a square one, or a ovoid one. So pontic, if it is as a lever arm, so torquing movement, it will cause offset to the torque. What does that mean? Now, if we have a pontic in this direction like canines, so this will offset the torque. It will provide the cantilevering of the torque if we are presenting. So this span should be always 3 times that of the span of the replacement. The front span, the antero-posterior span should be 3 times the posterior span when we are doing. So in square, what will happen? The span will decrease, so it is not favorable. In tapering, the span is increasing, so it's good for us. So more the antero-posterior span, more is a better quality of abutment that we are going to choose. For example, like this. Now here we have given this total abutment from one end to other because it had a good antero-posterior span. If I divide this line from here, if this is x, we had 2x quality of tooth present behind, so that is acceptable. Special problems come across the fixed partial dentures when it is planned. For example, pyre abutment, tilted molar abutments. We have canine replacement FPDs, that's a big challenge. Cantilever FPDs. What is a pyre abutment? Missing area on either side of abutment teeth. Now what will we do in that case? See, like this. This is a teeth missing on this side, missing on this side. So how will we go ahead with this? So what we do is we give a non-rigid kind of connector. You can see this non-rigid. So the stress will be broken here. So it is like 1 FPD over this side, 1 FPD over this side, and there is a non-rigid connector. So the stress is being broken by the male and the female parts. So this is all about the pyre abutment. So what happens is when there is a seating action, there is mesial movement. So when there is a mesial movement while the seating action is taken place, there is teeth which will not allow the prosthesis to go behind. So we are saving the abutment teeth as well. So non-rigid connector over here is important. Number 1. Number 2. The bending and the torquing force, because if this and this would have been abutment, there is a long span FPD. So the bending and torquing force would have been increased in this particular span. Now we have something else to take over the distribute the load. So now the bending and torquing force will be divided among these two and again these two due to the pyre abutments. Coming to tilted abutments, like this case of molar which is tilted. Now this is not parallel to the long axis, parallel to the end of this. The mesial end of the molar is not parallel to distal end of the molars. What will you do in these cases? These cases are dealt with in this picture. Like we can see, there is a post-treatment picture. This molar, we put a crown. Those type of crown which is put on the tilted kind of abutment is called the telescopic crowns. So on this telescopic crown, we will have our crowns. We will have our own bridges, fixed partial denture bridges. So now this is parallel to this. So the path of insertion is single path of insertion. Multiple path of insertion, it will come out easily. Single path of insertion, it will go and it will not allow to come out easily. Coming to tilted abutment, so the first option always remains is orthodontic treatment. If the patient is not ready for orthodontic treatment, you go for the telescopic crown as I showed you in my case. We gave a telescopic crown on this particular, making it parallel, making the walls each other parallel, and then going ahead with the fixed partial denture. Coming to canine replacement of fixed partial dentures. Now in case of canine replacement, since it's a corner teeth, very doubtful and very important to do the diagnosis. Because canine, if it comes out of the curvature, if canine is coming out of the curvature, it will give a bending force. It will have this twisting forces onto the entire fixed partial dentures. So the canine is not supposed to be outside the inter-abutment axis. This axis you can see is called inter-abutment axis. So the crown of the canine or the pontic of the canine should not be out of the inter-abutment axis when canine is to be replaced as a pontic. Cantilever FPDs, totally contraindicated. Only indicated in the case of replacement of missing lateral incisors. So where we can take the help of the canine and replace the lateral incisors. If it is in the case of molars, you are replacing a fixed partial denture with a cantilever, what will happen? The force acting on it will dislodge this particular restoration, because the force acting on it will also tend to put this crowns above from the abutment, because it will have a torquing force on these, because there is no abutment to support and distribute its force. Rather, it will give a torquing force on this and the abutments will come out. So, posterior edentulous span, no cantilever is indicated. Rather, we should go for removable partial dentures. The special investigations which are required to plan an abutment selection is vitality test, radiographs are important, IOPA, OPGs, both study models which is articulated to check the interocclusal space which is present. All these things are important to go ahead with abutment selection for a fixed prosthodontics.